Okay. Good evening, everyone. It's such a pleasure to welcome you to Alberta-wide nursing rounds. My name is Lindsay Komar, and I will be your moderator for this Zoom session. Alberta-wide nursing rounds builds on a foundation of our longstanding citywide nursing rounds, an initiative that has connected nurses, students, educators, and researchers here in Edmonton for many years. But now we are expanding our reach. By going province-wide, we are creating a space for nurses from all corners of Alberta, urban, rural, and remote, to share knowledge, raise questions, and build community. This is about amplifying the voices of nurses and ensuring research and practice truly inform one another. These rounds are about more than just sharing findings. They're about tackling the real-world issues that you face in clinical practice and celebrating the impact of nursing scholarship. Before we begin our session, I would like to take a moment for a land acknowledgement. The Faculty of Nursing at the University of Alberta is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. We recognize the First Peoples of this land, and we commit to working together toward reconciliation and equitable health outcomes for all Indigenous communities. A few quick housekeeping items before we begin. Today's session is being recorded. So if you want to access our recordings, Heather, I'm not really sure what we're doing about that right now, but you can email us and then we will for sure send it to you, or it will be on our website.
It'll be on our website, and I will talk to the powers that be, decide how we're going to distribute it.
Exactly. Okay, so if you're looking for a recording, please let us know. We're going to hear from three excellent presenters today. The topic for today's presentations is children's health, which is very close to my heart as a NICU nurse. So I'm going to our first speaker. I will introduce Dr. Shannon Scott, a professor and dean at the Faculty of Alberta, Faculty of Nursing, Stollery Children's Hospital Foundation Distinguished Researcher, and a previous Canada Research Chair in Knowledge Translation and Child Health. Dr. Scott is the principal investigator of ECHO, Translating Evidence in Child Health to Improve Outcomes, an internationally recognized program of nursing research focused in child health that cuts across multiple disciplines and merges research and the arts. She is also a founding co-director of Translating Emergency Knowledge for Kids, or TREC. Dr. Scott's presentation will demonstrate the breadth of child health research happening right here at the University of Alberta Faculty of Nursing in the ECHO Research Program. Highlight the work of TREC, and share what current undergraduate and graduate students at ECHO are researching. So Shannon, if you have slides, you are welcome to share them and start.
Perfect. Thank you. Thank you very much, everyone, for joining us today. And I'm so delighted to be able to co-present with two recent doctoral graduates from ECHO Research Lab, Dr. Chentel Cunningham and Dr. Lisa Knisley. The next slide, please. Thank you very much, Lindsay, for the land acknowledgement. We can go to the next slide. And I just wanted to state that we have no actual or potential conflicts of interest in related to the presentation. Next slide. And next slide. We can go to the next one. And before I begin, I would like to acknowledge my colleagues, Dr. Lisa Hartling, Dr. Terry Clausen, and Dr. Lisa Knisley, who I've had the pleasure of working with over the last 15 years. And nothing in research is conducted in isolation. We're constantly working in teams. So the work that I'm going to share with you today is premised and based in the knowledge translation field. And to situate us, there's two broad types of KT. One is integrated KT, where we've got our knowledge users actively engaged throughout the study, and end of grant KT. And KT is all about putting the research to work. Next slide, please. And another inherent principle in the work I'm going to share is patient engagement. And this is all about meaningful collaboration with patients. Patients become patient partners in the project and participate in aspects of the research, all the way from priority setting, developing the question, and performing parts of the research. Next slide. So the impetus for this program of work that has evolved over the last 20 years is that 85% of children who need emergency care are treated in general emergency departments that are not part of a children's hospital. So in Canada, we have 16 children's hospitals that have emergency departments where all of the specialists reside. However, given the geography of Canada, the bulk of children that actually need this emergency care don't actually go to PEDs. And also 40% of children get treatments for which clear research evidence do not get treatments for which clear research evidence exists. And 1 in 5 get treatment of which there's no benefit or may be potentially harmful. Next slide. So for the next couple of minutes, I'm going to talk about how over the last 15 years, I've worked with a parent advisory group and colleagues in the Department of Pediatrics to co-develop resources for parents to help them make healthcare decisions. Next slide. Now, the work that I'm going to be discussing is arts-based KT. And the strength of arts-based KT is that we can communicate complex health information and create understanding, all the while generating meaningful connections and emotional impact. And through our work, we've demonstrated that this approach can actually facilitate memory and retrieval of this important healthcare information. Next slide. So the goals of our work are about empowering parents and families in the development and evaluation of effective KT tools, to engage parents in decision-making about the use of health services and treatments, to collaborate, so using the power of arts and narrative to translate complex health information and to generate those meaningful connections and emotional impact, as well as to increase parents' knowledge and confidence in managing common childhood illnesses. Next slide. So here's an image of our co-development cycle. And this co-development cycle has evolved over the past 15 years. And I want to draw attention to the fact that at the center of the model, the co-development model, is our parent advisory group. And I want to highlight how critically important our parent advisory group is and how they're involved at all stages of the co-development process. If we imagine this cycle as a clock, if we start at 12 o'clock, this is where we do the research and we identify stakeholder groups and do priority setting exercises. Then if we move to between 1 and 2 o'clock, we start to actively engage parents who have experienced the condition that we are co-developing the resources for. We start to engage them in the process. And we conduct qualitative interviews to gather their information, needs, and experiences. And at the same time, we're also looking to the existing research, and we are doing systematic reviews and knowledge syntheses, looking at the diagnostic and therapeutic management of the condition under study, as well as looking at the existing literature in terms of parents' experiences and needs. And then we integrate the results from both of those steps to start developing tools to help parents make these critical healthcare decisions, such as, when do I need to take my child to the hospital? Can we stay at home and manage this condition at home? Or do we need to go and seek healthcare in the morning? So when we talk about tools, we're referring to things such as interactive infographics, videos, ebooks, and audiobooks. And the format to which we develop the resource is also based upon feedback from the parents. So once we develop a prototype of the resource, we then get the tools vetted by healthcare providers for clinical accuracy and by parents for content and perceived value. And there's many cycles of feedback and refinement that occur. We receive a lot of feedback from our parents in terms of the display of the information, um, the way we present it, and our parent advisory group is critically involved with that. So once we have a prototype that has been vetted and that our parent advisory group is happy and content with, we then do usability testing of our tools. So we go into emergency department waiting rooms, specialty clinics, and talk to parents who have acutely ill children with them and show the resources. And we ask them 10 questions on a Likert scale in order to assess the ease of use, how simple the information is. In recent years, we've also started an additional step as we co-develop our resources, and this is the cultural adaptation step. So while Canada is a very diverse country, and we purposefully are sampling parents of all backgrounds in our research and involving them, we have done cultural adaptation of our work for new population groups as well as for new jurisdictions. And so we take our existing resources, work with interest holders in the jurisdiction under study, and involve them in this adaptation work. We're also now starting to explore the potential for AI to help us with this stage. And then after cultural adaptation, we do dissemination of our resources broadly through the Translating Emergency Knowledge for Kids, a national knowledge mobilization initiative that my colleague, Dr. Lisa Knisley, will be talking more about later in her presentation. Next slide. So these are just some screenshots of the way that the knowledge translation resources look. All of the resources are freely available on the trek.ca webpage, and that's Trek with 2 Ks, as well on my research program website. So that's www.echokt.ca, and they're all freely available. And our resources are used all over the world. When you look at downloads, they've been used in over 40 countries around the globe. And they are actively played across Alberta in our healthcare system, in waiting rooms of emergency departments, physio waiting rooms, etc. So next slide. So just to give you examples, so we've talked about the co-development cycle. At each stage of that cycle, we are also actively working with research trainees and early career researchers and developing research publications at each stage. So this is just an example of a couple of the priority setting exercises that we have undertaken to help inform the topics to which we have developed knowledge translation resources. Next slide. We've also done effectiveness testing of our resources. So comparing our arts-based KT resources through randomized control trials with standard information sheets. So typically, parents who take their child for primary care or emergency care often get an over photocopied piece of information, a sheet of paper that outlines the condition that their child may be currently experiencing. And so we have also done randomized control trials to test the effectiveness of these resources. Next slide. And we've also written up all of the usability testing. We've used the preprint platform for usability, sharing our usability results, and then we are grouping our usability evaluations across multiple studies and writing those up as publications. Next slide. This just gives you a sense of where we've done our usability evaluation. We've tried very hard to go from coast to coast within our Trek network. So within Trek, what we've done is we have partnered general emergency departments with pediatric emergency departments, and as well as far north as in the Northwest Territories. So we've actively worked very hard to ensure that when we do usability testing, we're conducting it within urban, rural, and remote locations. Next slide. So in terms of the impact and reach, to date, we've developed more than 45 different knowledge translation tools for parents on more than 15 different topics, and the topics are listed on this slide. We have involved more than 20 highly qualified research personnel in this work. And as I've mentioned, just through advertising or disseminating our resources here in Alberta through Alberta Health Services platform and through HUTV, we get exposure to over 1 million viewers each month on the resources. And we're very grateful. We've received over $4 million to help fund this line of work. Next slide. I just wanted to share a little bit with you about our work with families and the effort that we've invested to actively work together with families. Next slide. So as I mentioned, we have a pediatric parent advisory group that we created back in 2016. And up to that time, we were going tool by tool and reaching out to parents and gauging their interest. Back in 2016, we decided to take a different approach, and we developed a parent advisory group that is a group of parent volunteers that meets monthly. They provide important advice to us in terms of guidance and knowledge from a parent perspective. They help us determine the next priorities that we need to be working on. We've also received funding from the Alberta Innovates Health Solutions and the Stollery Science Lab to really support the parent advisory group. And what else is quite unique is we embedded regular annual evaluations within the parent advisory group to be able to document parents' experiences and in terms of engagement. Next slide. So our vision with the Parent Advisory Group is really to advise child health researchers and to help parents and families feel empowered and make informed decisions about their child's healthcare needs. So in earlier days, the PPAG, as we like to call this group, was absolutely instrumental in creating and informing our research program. We also have leaned on the Parent Advisory Group to provide strategic advice for trainee work as well. And some of our collaborators have also reached out to be able to learn from the PPAG. Next slide. As I mentioned, we've published some of our evaluations collectively with parents to be able to make contributions to patient engagement science. And I just want to stress that doing patient engagement well is not for the weak at heart. It requires substantial resources as well as stamina to authentically engage parents and to meaningfully engage them in this work. So we have recently published a 4-year evaluation in BMC research involvement and engagement, as well as a 1-year evaluation. Next slide. So in terms of the key messages about working together with parents, we've really achieved a model where we can co-develop in true partnership KT resources with our end user group. Again, I just want to highlight the amount of time and resources and skill sets, as well as careful planning and ongoing evaluation. I want to say that we have co-chairs now for our parent advisory group. So parents actively lead all of the monthly meetings, and we're very happy with how it's evolved over time. Next slide. So in terms of the impact of this work, and I know that Lisa Knisley will be talking more about this later. So the parent advisory, the parent tools are just a component of TREC. So there's two arms to TREC. One are the resources for healthcare providers, and the other are the resources for the families that Dr. Lisa Hartling and myself work with parents to develop. But in terms of our connection with our TREC sites, we've connected with more than 160 emergency departments and nursing stations, and involved more than 2,400 healthcare professionals in some of the education sessions that we're also delivering as part of TREC. In terms of our online resources, more than 165,000 downloads of our free online resources. In terms of our parent videos, so we also put our video tools on a YouTube channel. We've received over 500,000 views on that channel. So next slide. I also wanted to just spend a minute talking about the cultural adaptations that we have done on our parent resources and the process through which we have done this adaptation work. Next slide. So as I've mentioned, in recent years, we've worked with diverse communities to learn how to take the KT tools that we have developed in partnership with parents to meet unique needs of different community groups, different populations. And I want to highlight that adaptation is really a key component of the implementation process. And it's based upon this idea, if you take an intervention, such as a knowledge translation tool, and modify it to fit a given context or a different group, that increases the likelihood through which it is used and enhances potential engagement and acceptability. Next slide. So across our evolving suite of more than 45 tools, we've been very purposeful to ensure that we have diversity already within the tools. And we want to ensure broad representation across family structure and roles, gender diversity and culture diversity, diversity in terms of ability and body size, diversity in age, education, and socioeconomic status. Next slide. So some of the questions we wanted to ask is, there was very little guidance once we started down this path 8 years ago about how to do this work. So how to take a knowledge translation resource developed in Canada and then use it in a different part of the world. And we wanted to understand, do we just need to translate these resources? Do we need to change the visuals? And how to make our resources resonate with multiple languages and culture groups. Next slide. So these are the different population groups that we have worked with so far. And I want to highlight, as I mentioned at the start, this work isn't done in isolation. We've been very purposeful and involved research trainees from undergraduate all the way to postdoctoral fellows in this work, and also have been very strategic in reaching out and receiving local, provincial, and national funding to help move the science forward. Next slide. So what we've learned over the last 8 years is that it takes time and care to ensure that all aspects of the KT tools are relevant to the interest holders. And translation for other languages and cultures can be time consuming and costly. But as I also made mention, we are starting to explore the use of artificial intelligence in this work. And efforts to examine how tools can be developed at the outset that resonate with multiple cultural groups is definitely warranted. Next slide. So questions that arose from these series of studies that helped inform our understanding was, The initial format of the tool and the mode of delivery, was this appropriate for each group? So we're definitely learning that sometimes videos are not the best choice if we're going to adapt it for a different jurisdiction or a different population. We've also started to consider if the storyline needed to be adapted for different groups based upon unique traditions. For instance, within some cultures, grandparents have a very active role in parenting, as well as different management approaches to unique traditions. And how do we navigate and manage this in the co-development process, as well as appropriate methods for evaluating the translated tools. Next slide. So some key takeaways. So when developing or adapting knowledge translation tools, the translations really need to go beyond the literal interpretation and include culturally relevant language and concepts. And that also highlights the important, if we go back to the co-development cycle, when we do the cultural adaptation work, we are then doing the usability evaluation cycle again. And when choosing the KT format, people really must be aware of the accessibility present in target communities. And we've had to spend a lot of time considering that. In terms of the visuals, we are also needing to consider depictions of diverse living environments, resources, as well as different relationships within family structures to increase relatability of the resources with the relevant group. And meaningful communication and collaboration stems from these meaningful connections with each community group. And each study where we've done cultural adaptation, we've meaningfully brought them in to the co-development cycle. Next slide. So in terms of some concluding thoughts before I turn it over to Dr. Cunningham, I hope that my presentation has demonstrated how this work is really at the intersection of integrated KT and patient engagement. But at this innovative intersection, we have been able to co-develop, along with our parent advisory group, more than 45 knowledge translation tools for parents to help them make important healthcare decisions. We are really about shaping parental decision making and increasing parent confidence about when to seek healthcare. And we're making meaningful impacts to patient engagement science through our parent advisory group and the annual evaluations, and making important new contributions about how to adapt interventions for new cultural groups. Next slide. I also wanted to do a shout out to all the trainees that have been involved in this work. We have involved more than 100 trainees and early career researchers in the ECHO Research Lab, and they have helped us explore multiple topics affecting children's health, such as concussion, congenital heart disease, functional constipation, anti-racism considerations in knowledge translation tool development. We've also worked on developing apps to help store and disseminate our KT tools, our cultural adaptation and sustainability work, and an area that we're just starting to explore is the use of AI for cultural adaptation. Next slide. And I just want to do a shout out to all of the support that has been critical in allowing us to do this meaningful work. And next slide. Feel free to reach out if you've got any questions. After the presentation, I'd love to hear from you. And ECHO Research is always recruiting outstanding graduate students and postdoc fellows and collaborators. So please don't hesitate to reach out anytime. Thank you.
Great. Thanks so much, Shannon. Okay, up next, please welcome Dr. Chentel Cunningham, who leads the Stollery Pediatric Heart Failure Program, the first subspecialty pediatric heart failure service in Western Canada. The program has been very successful, seeing over 650 patients to date. Dr. Cunningham is also the co-lead for the Home IV Milren I'm not even going to say this right, and I should know it. Milrenon program, a home therapy for children with advanced heart failure that strives to keep families together. Her advanced practice was the inspiration for her PhD, which she completed in 2024. Dr. Cunningham's presentation will focus on recent and ongoing nursing-led research in pediatric heart failure and knowledge translation.
Well, thank you, everybody. I'm super humbled to be presenting today, and it was an honor when Shannon asked me to co-present with her. I'm just going to try and share my slides here. Oh, hang on one second. Can everybody see my slides?
Yes, you just might want to do the slideshow. Yeah.
Oh, use slideshow. Sorry, one more button. All right. Thank you so much for having me present today. I'm presenting on filling the research gap in pediatric heart failure, past studies and future endeavors. Some of the things I want to touch on today are just give you a little bit of background about myself and how my work came to fruition. I'm going to talk about my 4 PhD studies and key findings and ongoing research projects, life after the PhD. I currently have no disclosures, and we've already reviewed a land acknowledgement of me conducting this research on Treaty 6. So my PhD journey is really heavily embedded in my clinical practice. I finished my BSCN in 2002. I can't believe I'm saying that already, but as soon as I was done my BSCN, I went swiftly to work in the PCICU, where I worked with a huge cardiac population and became fairly proficient in looking after those children and garnered my initial interests. I also was swift and within 6 months gained physicianless transport status on the transport team. And that really motivated me to get my master's with my advanced practice degree, because I wanted some independence and really just to demonstrate that you don't always need a physician to provide patient care. And so then after my master's, I was offered a position in the challenging role of pediatric cardiology, where I took that. And then 6 months, well, actually, no, maybe a year and 6 months after, I was approached by the divisional head to start the Western Canada Children's Heart Failure Service in Canada. The only one had been in Toronto. And then, of course, I started the Home Milrenon program. And it was through those experiences that I saw in my clinical practice that parent knowledge parents had gaps in knowledge about their children's heart failure and management strategies, and really couldn't remember any of the information that they told us. So I approached Shannon about doing a PhD in this, and this is really how all my work started. So just to give you a bit of background about how burdensome children's heart failure is, it accounts for 11,000 to 14,000 admission annually in the United States. There's currently no Canadian data, but I'm hoping that'll change now with the new Canadian Heart Failure Alliance. There's a lot of collaboration and knowledge sharing amongst healthcare practitioners, and really the focus on care has moved from survival to discharge and now focus on quality of life. But in order to do that safely, parents have to acquire a new body of complex knowledge very quickly. So when I approached Shannon, I started reading about knowledge and knowledge translation tools, and really thought that her work and her methodologies and everything really fit with what I was trying to achieve, but in the pediatric heart failure context. I thought I could really make a difference for these families and have something pragmatic, because I could reduce their stress, empower them to engage and help me make decisions in their care. I could reduce unnecessary healthcare accesses, such as telephone calls and unnecessary ED visits. And really the ultimate goal, what I wanted to have, was something tangible that I could improve their health outcomes with. I found that they couldn't remember all the things that I was telling them in stressful moments. So I wanted something that I could use and give to them that they could access multiple times. And as the evidence evolved, I wanted also for that tool to be able to be updated really easily. And of course, I had access to a patient population, so patient engagement for me was really easy, right? I had parents that cared, had been through it, so I decided that this was just a great fit and to start my PhD. So how I was going to do that was in 3 phases. So phase 1 encompassed an environmental scan where I looked for gray literature about parent tools about pediatric heart failure. In phase 2, I wanted to do a knowledge synthesis to see what was known and then use that to conduct qualitative interviews. Then I amalgamated that knowledge into phase 3. I wanted to develop a tool with Shannon's contacts that she developed previous tools with. And then I wanted to refine it with parents in the cardiology clinic. And of course, all academic work requires theoretical underpinnings and frameworks. So I used the structured approach to make change and change behaviors using the knowledge to action framework, which is rooted in the innovation of diffusion theory. My first paper that resulted from my dissertation was entitled Multimedia Knowledge Translation Tools about childhood heart failure and environmental scan. And this was published in 2022 in JMIR Pediatrics and Parenting. So I did that gray literature search using an environmental scan. And then I evaluated the health literacy of those tools using the SAM evaluation tool. I found 17 tools online using the advanced Google search. 15 tools rated as adequate, 2 tools rated as not suitable, and shockingly, 76% of the tools that were found were higher than a 9th grade reading level. No apps were found. And then I did qualitative interviews with key stakeholders who developed the tools and found that they were worried about timely and introductory knowledge. How much knowledge do we give them and when? And they were also concerned about incorporating credible and trustworthy knowledge. Challenges that the developers face were optimizing search engines. Would my tool be found when I used Google search, and how do I optimize that? Was some of their questions. They wanted to know how they could better include credible references. Do I include the actual reference? Do I make reference that this is evidence-based? Were some of the questions they had. Hitting on Shannon's cultural adaptation, they said that only having English language tools was an issue. And then finding time for refinements or updates to their tools were also an issue because that work is very burdensome and heavy to do when you're updating with new knowledge. The second paper that resulted from my dissertation, it's published in my dissertation and I couldn't get it published, and I'll describe why in a second, was entitled Caregiver Information Needs and Experiences in Heart Failure, a Qualitative Synthesis. I used the Handbook for Qualitative Synthesis to guide my synthesis. I originally ran the first search in June 2021 with a second researcher and Shannon as the senior researcher. And at that time, there were no relevant papers, so it was an empty review. So that was pretty telling that I needed to complete qualitative interviews. Then before I defended my research in 2023, I redid the search and reran it, and there was only one relevant paper, an Asian paper by Zhang et al. In 2023. So because there was nothing to synthesize, I didn't get a chance to do the meta summary or the meta synthesis part of the synthesis. So I submitted it to 8 papers. I even emailed, without being successful, I even emailed authors about empty reviews and how to get them published. But I couldn't do it. But that for me said enough that I had to do those qualitative interviews. So paper 3 was entitled Exploring Learning and Experiences Caring for a Child with Heart Failure, a Qualitative Study. So I use the methods qualitative description by Sandalowski and conventional content analysis to keep the descriptions as close to the participants as possible. I did 13 interviews ranging from 25 to 84 minutes. And those interviews were intense. There were tears, they were exhausting. My participants really made good descriptions, and I could really step in their shoes. The findings were category 1 and category 2. The first category being the traumatic diagnosis of heart failure influences learning. Parents told me that they experienced new ways of learning, anecdotally through nurses, through new literature which they had never seen, given to them by the healthcare team, and information they found on Google. The second subcategory was that stress steepens their learning curve. Some of the parents couldn't think after getting a traumatic diagnosis of heart failure, and it took them a while to get over that. And then category 3 was learning heart failure takes time. And that was really one that I like that it came out in the literature because, as a healthcare provider, it took me time to learn about children's heart failure. I couldn't imagine what a parent experienced. So just acknowledging that it takes time was a good thing. Category 2, a new life reality. Parents experienced an emotional roller coaster. They were mad, they were sad, they were in denial that their child had this traumatic diagnosis. And then subcategory 2 of category 2 was always on the clock, caring for a child with heart failure. Parents felt that having a child with heart failure, they were always on the clock. It was a constant job with no reprieve. So from those 3 papers, I worked with Renee from Anti-Gravity. Shannon gave me the contact who she had designed tools before, and I developed this infographic. Oh, sorry, I didn't see my bar was inverted there when I was changing the size, but some of the things I incorporated were that they could click on that bar and go to that credible, timely information when they want. If they needed something about medications, for example, they could click on it, take them right to the medication section. I wanted to make this infographic resonate with parents and seem real for them, so I incorporated some quotes from my qualitative interviews and had voiceovers so that it could be read to them, just so that they knew that it was real and based on evidence. In terms of health literacy and SAM scoring, I incorporated phonetic pronunciations. You can see in the middle there because cardiology often has words that are more than 2 or 3 syllables. So that would help parents know what we were talking about when we were talking to them in clinic. And then the whole point of this was behavior change and for them to learn how to care for their child. So I had summaries of most important information in bullets down in the far right there that incorporated things that they needed to do in order to care for their child. And before my final study and releasing this to parents, I SAM scored it for health literacy, and it scored superior, 95%. So it kind of met all of those check marks that we're looking for. My 4th and final paper, which I have ready for publication now, is the development, evaluation, and refinement of an online educational infographic for pediatric heart failure. So how I did that is I used Dr. Scott's modified usability tool based off a paper from Hornbeck in 2006, which is based on 180 usability reviews. And then I did a pre and post knowledge test, which consisted of a true and false knowledge test of 12 questions. The pre-knowledge test was before viewing the tool, and the post was after. And then there was a little portion for feedback, which we did qualitative content analysis on. So my usability was scored very favorably. So out of 5, its mean scores were 4.45 out of 4.7 to 4.77 rather. And pre-intervention score on the pre-knowledge test was 9 and post was a 10, so it showed an increase in knowledge. Scores in significant topics were when to take your child to the emerge, when I can't remember the other 3, but there were 3 topics that scored significantly. And then refinements were to reword the sodium intake portion, and then just aesthetically to make the headings bolder. So that was my PhD work. So now my current research endeavors post PhD include a lot of my qualitative work that I learned with Shannon. I'm a co-author on the updated heart failure guidelines. They're submitted and under revision in the Canadian Journal of Cardiology. So that was exciting for me. I got to learn how to use the grade methods approach with a statistician to develop recommendations for pediatric heart failure. So when those are submitted, I'll send them out to Shannon and she can disseminate them. I'm really excited about that. And while I was a student, Shannon and I were on a research grant application, which we were successful, called the Evans Research Grant. And we were awarded $300,000 for evaluating adherence and qualitative interviews on remote monitoring devices for kids with advanced heart failure and transplant, which we can use on children that are 100 kilometers or more away from the stollery. So we're just working on doing the final kind of tweaks on the analysis, and we're almost done the first draft. And then my third endeavor is I'm doing qualitative interviews to understand exercise in post-transplant pediatric population. I'm working with Dr. Michael Corey, and I have 2 students under myself. So lots of exciting things going on, and this is a non-exhaustive list. There's other things, but I had to pick a few to highlight. So I just wanted to say thank you to all my funders, Dr. Scott, the Faculty of Nursing. That's one of my home Milrinone patients there. So yeah, I'm really so glad that I did my PhD, and I'm going to continue doing lots of research in the future. Please feel free to contact me.
Thank you so much, Chantel.
Yeah.
Okay, so we have one more presenter. We're getting a little close to time, just so you know, Dr. Knisley. So finally, Dr. Knisley is an assistant professor with the College of Nursing at the University of Manitoba. Her research focuses on knowledge translation and knowledge mobilization in acute child health care. Dr. Knisley is also a co-lead for REACH, or Research into the Enhancement of Acute Care for Children's Health, a research theme at the Children's Hospital Research Institute of Manitoba that aims to improve the health outcomes and the overall healthcare experiences for children, youth, and families needing acute care. She is a co-director for Translating Emergency Knowledge for Kids, TREC, and Dr. Knisley's presentation will focus on the key roles of nurses in mobilizing pediatric knowledge, from the identifying knowledge gaps and co-developing tools to leading operations, implementation strategies, and engaging with local teams. Go ahead and share your slides.
Can you see? I'm sharing them. Can you not see them?
Yeah,
Oh, you can.
sorry. Yes,
Okay, I was like, oh no. Okay. I'm really happy to be here today. I'm joining you all from Winnipeg, so Treaty 1 territory and homeland of the Red River Métis. I'm a proud U of A alumni. I did my PhD at the University of Alberta, and I'm really happy to be with you all today and talk a little bit about some of the work that I'm doing alongside Shannon and many other people, as she said. And I accept the challenge. I'm going to get this done on time. So I'm going to skip some slides because I know I'm keeping some of you from dinner too. So that's not good. So off we go. Okay, so Shannon touched a little bit on knowledge mobilization and knowledge translation. And I hope what you come away with from some of the things I'm talking about today is like really the key work that nurses are doing across Canada in terms of mobilizing knowledge and translating knowledge in pediatrics. I'm focusing a little bit on emergency care through TREC, and the nurses that I've worked with through TREC, they are the ones who are implementing these resources into practice, right? They're doing the practical work and they're working with us to make sure that the tools that we create are relatable and usable in their settings. So I just want to thank them all. And the focus that I'm going to be talking about is around the healthcare provider tools. As Shannon mentioned, translating emergency knowledge for kids, it focuses on uh, sharing knowledge for families and also healthcare providers. And just to say, we're a national organization. We've been around since 2011. Shannon was a founding co-director. I joined as a knowledge broker, became the executive director. When I got my PhD, I became a co-director and I oversee the administrative center here in Winnipeg. This is just a quick snapshot, of all the work that we've done over almost 15 years, which is pretty hard to believe, but we're really proud that we've created a national infrastructure where we are focused on creating tools, useful tools, right, to get the latest evidence and knowledge into the hands of families and into practice as well, really to ultimately improve care for kids. So, we co-develop resources, we focus on networking across the country and beyond. We do research as well, and I'll touch a little bit on that, and we do education as well. So I'll share a little bit about that. So around the co-creation of tools, this is with healthcare providers. This is just an example of some of the tools that we create. Really short bottom line summaries, we call them. They're short 2-page summaries of, what do emergency care providers working in rural and remote settings and non-pediatric centers, what do they need to know when a kid comes through their door? So we created them with them, the topics that we focused on. We focus on with them. We also create clinical tools like all treatment algorithms, order sets, checklists, all really to get the evidence into their hands in a useful way. Everything I talk about is on our website today, trek.ca, so please go and see more about who we are and what we do, and they're all freely available for anyone to download. So in terms of the healthcare provider tools, we follow a similar model to the ones that Shannon and Lisa Hartling have built through the parent tools. We have a dedicated coordinator. We work with content experts to create our healthcare provider tools. We focus on emerging trends. Shannon did a very large needs assessment over a decade ago, which really helped us to determine and prioritize the tools that we were focusing on for healthcare providers. When COVID hit, we knew that there was more children coming into emergency departments with eating disorders, for example, respiratory distress. So and we created tools to address that. So these are some of the ways that we prioritize some of the work we do. We also go to the evidence and synthesize that. And we create something called evidence repositories, which you'll be able to find on our website. This is led by Arch at the U of A under the leadership of Dr. Lisa Hartling and the team, but really to look and do evidence reviews. And we're very transparent about the evidence that we're using to create our tools. People can go to the website, download these PDFs to see how we've informed our tools. And then we co-create these tools with content experts. And I just want to highlight one of them, Dr. Mandy Newton, nurse, Department of Pediatrics. She's one of the content experts for the suicidal risk screening and assessment tool. So there are nurses that are leading the development of these tools. And I just really wanted to highlight that. So it's a national process, very rigorous. We have editorial committees where we review it for accuracy. We have knowledge mobilization committees that are made up of people working in these general emergency departments that look at these tools. We have parents and youth that also provide guidance on the healthcare provider tools, making sure that the way we talk about discharge or communicating information to them that we're using language that is appropriate, and we're doing considerations for communications. And I just want to highlight, these are all the nurses that are involved in all of our committees. So we have close to 20 nurses that are dedicating their time. They are advising on helping us to prioritize the tools. They're looking at the formats. They're providing their clinical expertise. And actually, this Alberta's missing a little bit here. So I really want to say we have a lot of, like, we've got obviously Shannon and many others in Alberta, but if anyone is ever interested and wanting to take part, I really encourage them to get in touch. Nurses are really important to get your input and your clinical expertise into the resources that we create. So I just wanted to highlight that. And we're just thankful for all of these nurses that lend their time for the creation of our resources and time on these committees. We also adapt them with Indigenous Service Canada for nursing station use. So we do adaptations as well for the healthcare provider tools. And just to, put it all together, when you go to Trek, we hope for as many topics as possible that you're going to find, if you're a healthcare provider, you're going to find a tool for you to use in practice. And you're also going to find tools that you can share with families as well. So really that wraparound of knowledge and sharing of these tools. And again, for group. So we conduct education sessions as well. I wanted to let everyone know that we do some virtual sessions here in Manitoba, but we record them and they're all available on our website. And so they're freely available for people to take a look. And also that starting in March of 2026, we're going to be doing a national webinar. So please sign up for a newsletter if you don't already. It's going to be on pain, and it's going to be led by Dr. Samina Ali, who's a pediatric emergency physician at the Stollery. And so we'd love to see you there. And so I know it's 9 o'clock, so I'm going to wrap it up, but just to say we do research. And a lot of the work that we are doing has informed other national networks. So there's networks like Rare Kids Can, which is focusing on improving access to clinical trials for children and treatment for children with rare disease. And I think Annie Mabbitt's here as well, who's doing a lot of great work for her PhD to learn about the information needs of families with children with rare diseases and their clinical trial needs. So watch that space. And Popcorn as well, which is another national network. So all of this work you've heard of today is informing knowledge mobilization and knowledge translation for other networks across Canada. And I'm proud to be part of these networks as well and learn from them and share what I've learned to date. So I'm going to wrap that up and on time. And so I just want to thank everybody for all of your time today. And these are all, of course, all the funders. And if you ever want a longer version or more information, my email is there, and I'm more than happy to share more of the work we're doing and any resources or how you'd like to get involved. And that
Wow, thank you for that. That's just amazing work. I'm overwhelmed at what the three of you presented, because it's just so exactly what we were hoping for when we started these rounds. Is like, where do nurses go to get this information? And we always we teach evidence-based practice, but no one has time to go to the evidence to figure out what they need to do, and especially in pediatric care. It's just so, you have to be on top of it, and to be able to pull these resources. I used to work in the PICU, and I can't imagine had I had those in hand. It's just brilliant work, and I'm so proud that it's nursing that's leading this all. So I really want to thank you for coming today, and for everyone who attended. And it's honestly, I'm just overwhelmed. I have so many ideas going for the stuff I'm doing and how to improve it, based on what I've learned tonight, which is what we're all trying to do right in our work. So we are developing our schedule, just by the way, for the nursing rounds starting in January. And we're just really, please tell anyone we're trying to get nurses just involved to see, and not necessarily what the science is, but how it translates to their practice. This was a great example of it. So we'll have to be sharing this recording around. But we also have a survey, and I think Heather put it in chat, but we might just email it to everyone who registered anyways, just to get more information about when is the best time to have it, because we've tried a bunch of scheduled times, and it's kind of an issue for, well, it is obviously an issue for anybody that's a nurse or doing nurse related work. So please tell anybody you know. We're excited to continue doing these, and I can't thank you enough. The three of you, Dr. Shannon Scott, Dr. Chentel Cunningham, and Dr. Lisa Knisley is close.
Really close. Knisley.
Knisley. Oh, okay. Well, I
Not
didn't do
easy
the
one,
K.
but I was super close. Yeah, thanks.
Yeah. I just saw a comedian on one of the social media things and talking about the English language and all the letters that are silent letters. And he does these sentences. You don't have a clue what he's saying, dropping out a knucklehead and knucklehead. Anyway, thank you very, very much. And it's so great to see the work that's continuing to progress, but it's also at every level, right? The students are learning about it, and masters, and have Chentel talk about her experience in practice, saying, I need to go back, but I also need to continue, right? Like it's once
I
you
know
get the
this was
bug.
posted at the Stollery to the advanced practice nurses, so it did get out to all of us. So
Yeah.
but-
Yeah. So thank you for attending, and thank you for your
And
input tonight.
there is a question in our chat.
Oh, okay.
Yeah.
Where is the question? Why don't you read it to us, Usha?
Yeah, it says like, I am, pardon if I'm pronouncing it correct, I am Tambini Monsisia. I'm sorry if I'm correcting that, like not pronouncing it right. Visiting scholar from Tanzania. In low literacy and high hierarchical clinical settings, nurses often face resistance, which leading patient education efforts. From your experience, how can we design knowledge translation content that is culturally acceptable and reduces resistance from doctors?
Great question. Chantel, did you want to start, or you had your mic
Yeah.
off?
Yeah, I was gonna say, well, your experience is sometimes not different from mine. Being from cardiology, sometimes I still feel as a woman I'm in the old boys club, and you have to have a strong personality to work in pediatric cardiology within the Stollery. And there's a lot of opinions, and it's just that, it boils down to that people really care about their patients. But how I deal with it, so I created the tool for parents, and I give that straight to the parents. That tool that I created is on our heart failure website, as well as we give a handout with a QR code on it, so parents can see the evidence and read it for themselves. I spend a lot of time with the patients, more than our kind of male cardiologists. So I do the education. I do a lot of, and I run an independent clinic as well. So I spend a lot of time with my patients. And I run clinic with the physicians, and I make sure that they practice evidence-based, and I do in a professional way call them out if they're not using the most recent evidence, right? And I'm not sure if that's acceptable where you're practicing, but that's kind of how I approach it. I have a strong personality too, so does that answer your question?
Yes, thank you very much. I do appreciate for that answer.
You're welcome. Thank you for tuning in.
Thank you.
Okay, well, thank you, everybody. And we hope to see you next month, and bring all your friends. Or I guess it'll be not next month, it'll be January. So thank you very, very much for your attendance. Take care, everybody.